This is an outpatient consult submitted by a surgeon. It contains 286 words. To figure out what it's worth, we need to determine the level of care by taking apart the history, the exam, and the medical decision-making, and plugging that information into this table, which shows the documentation requirements for outpatient consult services. For these encounters, 3 out of 3 key components are needed. You can use either the 95 or the 97 rules to complete the encounter. In this case, the 95 rules work out better for the surgeon, so those are the ones we'll use. Starting with the history, this is the table we use to figure out what level of history has been recorded. Here the doctor has documented the reason for the consult, along with the requesting physician. Looking at the HPI, he says we have a 43-year-old female with a history of diabetes who presents with a 2-week history of right upper quadrant colicky cramping pain that at times will radiate to the upper mid-back with associated nausea and worsening with consumption of lettuce and pizza. Looking at the rules for the HPI, this is either a brief HPI or an extended HPI. Looking at the HPI elements, here he's commented on the duration of the problem, the location, the quality of the pain, associated signs or symptoms, and modifying factors. That means this does qualify as an extended HPI. The next step is to check the PFSH. Looking at the PFSH, here the doctor has included one element of family history, social history, and several elements of past medical history. Therefore, this is a complete PFSH. The next step is to check the ROS. Looking at the ROS, it's apparent that multiple systems have been reviewed. He says ROS is positive for nausea and epigastric and right upper quadrant pain. She denies fevers, chills, shortness of breath, chest pain, constipation, diarrhea, rash, bruising, hematochezia, jaundice, hematuria, joint pain, swelling, arthritis, anxiety, bipolar, depression, headaches, or visual changes. This adds up to 11 systems reviewed. When you put it all together, we have an extended HPI, 3 out of 3 components of PFSH, and 11 systems reviewed. Therefore, this adds up to a comprehensive history. So the first key component is now known. The next step is to check the physical exam. Looking at the exam, the 1995 exam is based on the examination of organ systems and body areas. This physician has mixed and matched organ systems and body areas within the same physical exam. When you add it up, he has 4 body areas and 7 organ systems. This is where it gets a little dicey because we all know he's going for the comprehensive physical exam, but this level of exam can include only organ systems, not body areas. So at first glance, it would appear that he could not qualify for a comprehensive exam because that requires 8 organ systems. However, in my opinion, I think it would be fair to give credit for the respiratory system for his chest exam and the GI system for his abdominal exam. This would give him a total of 9 systems, which would indeed qualify for a comprehensive physical exam. The next step is to check the medical decision-making. Looking at the medical decision-making, it's always a good idea to take apart the assessment and plan using the medical decision-making point system. Starting with the problem points first, here the cholelithiasis would count as a new problem with additional workup planned in the form of the intraoperative cholangiogram. That means this problem is worth 4 points. The diabetes would count as a new problem with no additional workup planned and is therefore worth 3 problem points. This adds up to a total of 7 problem points. Now that we know the problem points, the next step is to check the data points. Looking at the data points, here he'd get 1 point for ordering and or reviewing labs, 1 point for looking at the ultrasound report and ordering a chest x-ray, and 1 point for ordering an EKG. This adds up to a total of 3 data points. The last step is to check the risk. Looking at the risk, to be honest, I'm not quite sure how to score this, but there is documentation of several risk factors for surgery. So I'm going to give credit for elective major surgery with identified risk factors, which would make this a high-risk encounter. So looking at the medical decision-making, we have 4 or more problem points, 3 data points, and high risk. Since only 2 out of 3 dimensions are needed, this adds up to high complexity medical decision-making. So now the final key component is known. Now that we know the key components, we can select the level of care. Here we have a comprehensive history, a comprehensive exam, and high complexity medical decision making. For consult services, all three key components are required, and in this case, all three key components point toward the 99245 level of care, otherwise known as a level 5 outpatient consult. When you put it all together, this is how the final note looks. We have a comprehensive history, a comprehensive physical exam, and high complexity medical decision making, which adds up to a level 5 consult. So here it took this physician 286 words to earn $244, which works out to 85 cents per word, which is pretty good documentation efficiency. Thanks for watching Case of the Week. If you want to learn how to document your encounters this efficiently, consider signing up for one of our web-based E&M coding curriculums. We offer several different subscription options to match any practice pattern. For E&M coding education for multiple providers, let us build you a customized E&M compliance web portal, which provides centralized, trackable, and verifiable E&M coding education for multiple doctors.